Okay, so I think we should return to the board meeting. We now move to item 8, which is the expression of interest for the hospital infrastructure programme, and I'd just like to remind colleagues of the context of this discussion and just be clear what we need to do today and where it sits. So those who have been on the board for a while will have a lot of background on the need for investment in Horton General Hospital, and also for the importance of the Trust's commitment to work with the local community to understand how we can best develop services on that site. They'll also be aware that this is partly an issue for us and it's partly an issue for our commissioners. So some of the issues about what should or shouldn't be provided at Horton General Hospital sit within our gift, and others are a question of the NHS commissioning. We've been working with stakeholders, and that includes active involvement from the Special Joint Health Opium Scrutiny Committee, local MP, Keep Horton General campaign over a long period on developing a plan for the site, and that sort of went into slow move during COVID, and we have previously hoped to find a place on the hospital infrastructure programme. We didn't make it in the first round, but we knew that there would be a second opportunity to bid for the remaining 8 places on what were announced as being 40 new hospitals. And on, I think it was July the 15th, so only a few weeks ago, the deadline was announced for tomorrow to put in expressions of interest. In a different world and a different timetable, we would have hoped to have been able to have a formal consultation with our Joint Health Overview and Scrutiny Committee to test out their ideas. That committee is not currently constituted, and couldn't meet in the time that we had in place, but the County Council circulated it to members of the Joint Health Opium Scrutiny Committee to give us a chance to feedback, and comments that have come in from that have been circulated to all of us to make sure that we're aware of the views that are there. In summary, though, the Chief Executive of the County Council has confirmed that there is support for us putting in the expression of interest. That's our actual key decision today, to put in this expression of interest. And if we don't put it in, we're definitely not going to get the money. So I would be very disappointed if you don't give us agreement to put in the expression of interest. If we do get the money, of course, that's the beginning of a process of refining the business case, how we'd use the site. So it's the beginning of a phase if we get the money. And so what we really want to be able to do today is to get support for the submission of the expression of interest. We've put a lot of effort over the last probably years and months in trying to understand what gives us our best chance of winning the money. So the expression of interest is the sort of combination of discussion we've had with stakeholders about what we need, the discussions that we've had, and which political colleagues, including MPs, have had, trying to tease out what we think it is that the government is wanting to fund, so that we can bring those things together and make the best available case. We've worked with our colleagues within the NHS also to understand what within that structure hits the priorities. So we have, I think, an opportunity to put in this expression of interest. We haven't had formally the discussion with the HOSC that we would have had in a different sort of context, but all the issues that have been raised there, I think, are supportive of us putting down in the expression of interest, but there are obviously some markers about things that might be thought about as we refine the process. I want to absolutely reiterate the commitment we've given before as an organisation to working with stakeholders to try and refine this, and the fact that we're having to do this over the summer and in the first meeting in the autumn has meant that those engagements have had to take a slightly different form than they would have done in a different, more protracted timescale. But I do think we're an exciting opportunity to make a bid for the money, and I'm hopeful this will find favour. And I'll hand over to Sam to say a little bit more about what it is that we're putting into the bid. Sam.
Thank you, Chair. And just to clarify roles here, this will be a bit of a double act from myself and David. Myself, who has the executive leadership of the Estates and Capital team, and David, who has the executive partnership role. So I'll talk a little about process from an estates perspective, and then hand over to David to talk about working with our partners and colleagues. So as the Chair has already stated, the primary purpose of this paper is to seek approval from the Trust Board to submit the expression of interest for a place in the Health Infrastructure Programme, and that expression of interest is due at noon tomorrow. So Department of Health and Social Care have invited expression of interest from Nhs Trusts who wish to be considered for the next wave of this programme, which has been set up to deliver a commitment of 40 new hospitals by 2030, of which there are 8 places remaining. Now, given the age and the condition of the buildings at the Horton site, the vision is to replace the hospital in its entirety to create facilities that are safe, fit for purpose, and can service a growing population and accommodate some shifts in activity from the Headington sites and provide care closer to home for people living in the north of the county. The total estimated capital cost of the new build, including VAT and equipment, is therefore circa £350 to £370 million. Should the initial expression of interest be successful, which we'll expect to hear around autumn time, then a much more detailed submission will be required, and details of this proposal remain indicative at the moment, and David will probably expand on that. The preparation for this expression of interest has been discussed at a number of board level meetings. The executive have shaped the initial EOI for discussion, which took place at Integrated Assurance Committee in August. This raised a couple of areas for further scrutiny, which were explored at the Investment Committee, such as level of confidence in the proposed total costs, and following our experience in the new build, the new critical care build, which is nearing completion, which has got a short design phase, shortened business case cycle, and a modular build approach, there was a level of confidence felt by Investment Committee. And in fact, the new clinical director for new hospitals is visiting our organisation this Friday to look at our experience of that critical care build. The Investment Committee also noted that both the Trust clinical strategy and wider BOB ICS strategy would be considered as part of our wider and future work with colleagues to ensure alignment should the bid be successful, as would any further commercial opportunities. The Investment Committee also noted that stage 2 of the selection process will require a more detailed submission, and it's anticipated that that final decision on successful bids will be made in spring of 2022. So I'll close here with the recommendations of the paper and pass over to David. The Investment Committee noted the work undertaken to date and recommended that the Trust Board proceed with the expression of interest in line with the final draft that came through to Investment Committee. So the Trust Board is therefore asked to note the context of the work undertaken to date in connection with the preferred option for the redevelopment of the Horton Hospital site and approve the expression of interest in line with the appended final draft. But before I hand back to the Chair, I'll just hand back over to David for his partnership experience and work to date and future plans.
David.
Thank you, Chair, and thank you, Sam. I will be succinct. As Sam and the paper highlights, the EOI sets out an exciting vision for the Horton, which will provide flexible and adaptable clinical space as we move forward with any expansion across the site. It's important from a stakeholder perspective, the approach to construction, which facilitates, by definition, improved ways of working and enable delivery of integrated care across health and social care, and indeed wider public sector parties. The EOI isn't the final proposal. This will follow if, as we all hope, we are successful through the HIP process. So over coming weeks and months, we're very much looking forward to work with all stakeholders in North Oxfordshire, including HOST, campaign group, media, politicians, and importantly, commissioners, so that we can start developing the bid detail as we move through. And as you touched on, Jonathan, the notification between launch of the HIP and the submission meant, and also summer period, meant that we perhaps didn't do that as much as we would have liked before the submission, but it was still comprehensive. So over coming weeks now, once we'll put the submission in, become aware of the process, it's about working with our stakeholders now to make sure that we get a really strong bid for Horton moving forwards.
Thanks, David. And I think I'm right in my view that the content of this bid is substantially what has been shared in a number of meetings as it's developed through. Obviously, it's a very high level and things will emerge in the more detailed thinking, which won't have been seen by stakeholders and they'll want to comment on and develop. But broadly, this is the same bid as we shared at stakeholder meetings, and we've discussed, Bruno and I, with the HOSC at the last formal meeting, which I think was February. So we haven't changed our plan on this. We're just trying to focus on securing the funding for it. I've got Katie and Megan. I'm not sure. Megan, I might let Megan go first, Katie, because it could be that she wants to add the sort of contextualization. So Megan first.
Thank you, Chair. I think the key thing is to, that we all recognise this is a huge opportunity for us as an organisation to improve the buildings and the care for the north of the county. And it's an opportunity that, we have, albeit within 4 weeks, seized as best as we could. And this is a high level EOI. So I hope the Trust Board will approve this bid, which is a fantastic opportunity.
Thanks, Megan. Katie.
Thanks, Chair. Yes, as most of you know, I'm non-financial in background, but I just wanted to say a couple of things. Firstly, I want to acknowledge the huge amount of work that this takes with no guarantee of successful outcome. So I want to acknowledge and thank the team for that. And secondly, my view is that it's always better to be in the game with these situations, because if at any time you don't put yourself forward for something like this, then your profile recedes and you are at risk of showing yourselves to be disinterested, which obviously we are not. So I'm fully supportive and just wanted to make those 2 points.
Thanks very much, Katie. I mean, I think it's not just the production of the outlines that has taken a lot of effort. There's been a lot of effort in talking with and listening to various stakeholders in the community. There's been an awful lot of testing out with NHS partners and political partners what it is thought to be likely to be successl, and aligning that with what we have to offer. So I think we're putting our best shot at this, and then I think we need to see what the process is. Of course, the constant contact and checking out, and I'm sure on our political partners' side, lobbying will no doubt continue on the back of this, but we need to give it a green light today in order to get to that stage. Anne.
It was really just to reinforce the points that Sam made from the Investment Committee. The Investment Committee did have the opportunity of reviewing this proposal in more detail and was fully supportive of submitting this expression of interest. So I just wanted to make that absolutely clear. So it was a very positive endorsement of submitting this. So thank you.
Thanks, Anne. Anita, this is a meeting of the board. I can't take questions from the public. I'm confident that the local community wants to see this happen, and I'm therefore going to put to the board that it should support the expression of interest. What I want to absolutely reiterate, as I did at the beginning, is of course this is only one step in the process, and we will be working closely with stakeholders to refine the proposal as we get the chance, and I'm sure, Anita, you will be a strong participant along with colleagues in that. So can I take it that the board, on the basis of that discussion, is supportive of us submitting the expression of interest? Great. Yeah. Thank you very much indeed. That then takes us, and we mustn't raise expectations. I know the BBC sort of portrayed that we somehow got £370 million yesterday. We would love to have that money, but this is our route to bidding for it. And we must be clear that the next step is not our choice. That doesn't mean that we won't put our best efforts into influencing it. But we can't get there without putting this expression of interest, and that's the decision we're taking today. Thank you. That moves us on then to the financial governance review. The issue here is not the receipt of the report, but it is the noting that it's coming, because that's because we've done that previously, and having a look at what we plan to do next. And I'll hand over Jason to introduce that.
Thank you, Chair. Well, you've stolen a little bit of my introduction. Yes, exactly. Board members will know that they have seen a nearly identical version of this report in private. We just ran it through various comms teams, and a few bits of language was simplified, for example. But we did feel quite strongly that actually, for transparency, if nothing else, we would put it in the public domain via our papers. Board members should all have seen as well an earlier version of the summary action plan being developed in response at the IAC, and that's developed a fair bit since. Actually, when we broke up the IAC conversation, I think we were considering whether or not the formal approval of the action plan should take place at this meeting. And some of you will remember that I remarked that I was pretty much going on leave straight away after the IAC. There were some good conversations, I think, both at the IAC and afterwards about exactly where we want to get to on this. And so actually what I've brought is a slightly modified version of probably the what was envisaged at IAC. So what the paper is doing, in addition to noting those first two documents, is suggesting that what we should actually do is approve the full plan at the next IAC. And actually to avoid having to wait until November, because some bits of work are already underway and more will be underway before November. So asking the board to actually delegate to IAC the approval of the plan. One of the bits of discussion at IAC and in some of the conversations subsequently was that while the format appended to this paper is actually quite concise, which I think we all should like in context of the size of our board paper bundle. Actually, one function of it being concise is it actually doesn't have some useful detail, for example, on milestones or measurement of achievement and such like. And so what I've started to develop since returning from leave, but isn't ready for today, and therefore will go to the October IAC if you all agree via TME, is a second, more detailed sort of program tracking format. And probably IAC will see that once, I think, Chair, so that it, well, at least once, so that it is confident in sort of the format, and then we'll work out the sort of future reporting. And an updated version of what the board's got here will be used more for the sort of public facing and also engaging with some of our external stakeholders like the ICS and the region, so that they can see something sort of concise, but actually that ultimately the board can be assured that there is a level of granularity we can track against. And then the last piece that was discussed at IAC, and we've gone away to have a little bit think about, is where the program management of rolling out this set of improvements will take place and how that will be assured. And so the final thing the board's being asked to approve today is the proposal that actually TME will function as the program management group. We've had a discussion at TME. I don't think we want to set up a further meeting, which if it has everyone at TME will feel like an extra TME, and if it doesn't have everyone at TME, we'll probably be missing some of the key people that would need to actually oversee the program. And I think it was fairly natural, actually, probably that IAC does the assurance for the board. The final piece I would just sort of add, which is referenced in the paper since we met at IAC, is we took advantage of an existing scheduled meeting of the Performance, Workforce and Finance subgroup of the Council of Governors to brief some of the governors on the key headlines of the report, telling them that the full report would come out last week, and that we'll be discussing it at the next Council of Governors. And I think, although Neil offered to do this for me and I'm not a member of the Governors Forum, so I haven't actually verified this, I think the Governors also got just a slight early run, sort of a few hours or so in advance of the report, actually full report via Governors Forum post. So we've briefed Governors as well, but there'll be some more conversations to take place.
Thanks, Jason. We shouldn't underestimate the interest of governors in this. I mean, this is a crucial part of the jigsaw puzzle of us responding to the outstanding bits of the Deloitte review, and also picking up the challenges of our year-end positions as I arrived. I mean, I think we know the content of this, so we're noting that. I think we need to have a sense that the broad direction of travel for the action plan is what the board is expecting. We're not, though, asking the board to say this is an action plan which we're approving. We're asking the board to say it needs a bit more work and detailed review at IAC. And then I think we're aiming to draw a distinction, as Jason has just pointed out, between the assurance function, which sits with IAC, and the responsibility for making things happen, which sits with the executive. And the proposal is that that's the executive collectively in the TME, which makes a lot of sense to me, and it avoids duplication. And whenever you get duplication, you have the risk that there's a slight gap between the processes. So I think I mostly want to encourage discussion on, does the summary action plan broadly cover the right bases? We can pick up the detail of it later on, but if we don't think as a board it's setting us up in the right directions, then we would be a bit cautious about the proposed steps. If we're happy it's there, we'll have a chance to go through the detail when it's had a little more revision and the IAC has had a chance to look at it. Jason,
so there's one thing, bit of detail actually then, just before we get into general discussion. What the paper says is I've listed out a specific set of bits of the feedback that IAC gave that are not yet incorporated in this summary, and will be incorporated both in the detail and the summary by the time IAC sees it. I won't list them all, but actually to avoid board members needing to make the points again, several of you will spot things that you'll remember saying at IAC that are captured as things we're working on.
Thank you. So we don't, I think, need a prolonged discussion of this, because actually we've had quite a long discussion and we will have a long discussion. I do need to know that the board is confident that that way of proceeding is going to give us the grip that we need, which I think primarily ends up with TME taking on responsibility, and the assurance we need, which will come through being clear what the action plan is in the first round of IAC, and then being able to get it in monitoring from IAC in the future. Are we happy that that is the appropriate way of us making sure? I've got a thumbs up from Katie, so I'm going to take it then that we are happy with that. That's a relatively short item for a very big piece of work we've already had. We had with Horton, and quite a lot of work that we already we will have ahead of us. But I'm pleased that therefore we're able to approve those recommendations in the report. And I'm going to move us on to item 10, which is the Equality Standards report. Terry.
Thank you, Chair. So I'm going to take this paper as read, but I will highlight some key points. It's also worthwhile noting that this has been through the Equality Diversity Steering Group and had been changed there, and has also been to TME and received approval there. One thing I do want to highlight that, despite the difficulties that faced by the Trust in the last year, there has been significant improvement in performance in a number of the metrics, as you would have seen from looking through the paper. That includes a number of the number of disabled staff receiving reasonable adjustments, the bonus and the pay gap, and I think it's important that we should promote these improvements and celebrate them. However, there are still areas for improvement. Some of these improvements are in relation to processes, so like developing systems to enable regular reporting of EDI data, conducting data analysis of the medical res, working with staff survey providers to receive further protected characteristics breakdown, and designing and developing signposting processes for staff networks, so that actually, rather than having to deal with issues themselves, they know who to send it to, and it's quite clear. But others are cultural, such as utilising trust leadership and management training to build capacity and self-awareness in relation to bullying, harassment and discrimination across all of our leaders and managers in the organisation. Also, things such as increasing the competence of the senior workforce and culture and leadership team to tackle discrimination and to embed those approaches in their work, in their teams and the trust. Also, ensuring that managers are aware of their duty to undertake reasonable adjustments and create escalation processes for this when that's not the case. I feel quite passionately about, that needs to be a culture change. We shouldn't be looking at, okay, this is a financial issue. We need to be aware of the financial issues, but we also need to make sure that we need to look after our disabled staff when they need to, when we need to. And also a bigger piece is around considering the EDI recommendations from the National Future of the NHS HR and OD programme and determine an implementation plan. We've also got a number of trust-wide work streams, such as Growing Stronger Together, the Just Culture piece, the EDI Objective Refresh, and they provide huge opportunities for us to improve on our RES, our WDES, and our gender pay gap. But it's worthwhile noting that this is a work in progress. I am confident, though, that as a board and an exec team, we are prepared and willing to make significant improvements in this place. So, having said that, I'm going to leave it open for questions.
Thanks very much, Terry. I mean, there's a lot of evidence here of effort and incremental improvement. It's not perfect, but it's mostly going in the right direction. It does take a long time, though, doesn't it, to move these things. So I've got Claire, and then I've got Katie, and then I've got Joy, and then I've got Paula. So Claire first.
Thanks, Jonathan. Can I just agree with Jonathan that there's been a lot of effort put into this, and I think real care around it, which is really pleasing to see. Just a couple of specific sort of issues. First of all, I wasn't sure how much training we'd done or planned to do in this area, because under the sort of actions taken since 2020.3, I couldn't really see any specific focus on that. So perhaps you could just tell us a bit about that. And then really a comment from my experience of working with Scope for a long time, the disability charity. I absolutely support what you just said, Terry, about a change of culture. And although I think we all understand where the phrase reasonable adjustments comes from in law, it's quite an unhelpful way of thinking about disability, I think. And what we need to encourage people to do is think about how we can create an environment where disabled people can give of their best and do the job in the right way. And so I would really welcome your suggestion about bringing budgets more centrally, because I think that helps, but we also need to encourage people to think differently too.
Thanks. I think we'll take the questions, Terry, and give you a chance to answer at the end. But if you want to jump in, no, tell me, Katie.
Well, mine are comments really. Firstly, as Terry said, we've discussed this quite a lot in the EDI working group. And the only other thing is I just wanted to make sure that we don't lose the ability to connect this to the freedom to speak up work as well. So I know we're going to defer the discussion on that until October, but there are obviously some linkages. So I just wanted to highlight the need to do that. Thanks.
Thank you. Joy?
Yeah, thank you. I was just going to commend the amount of work that went into producing some of this work, and there is a lot of consideration in the paper, so I definitely agree with that. I had a couple of questions. One, there's something about a centralised pot for reasonable adjustments, which I wondered what the status of that was, because it feels like it's a really good recommendation, and it would be important, I think, for people to not feel that they would be disadvantaged through any reasonable adjustments that might be taken out of their own budget, especially given what the conversations we've had about the finances. Should I go on, Jonathan? Yeah. The second question was to do with the BME well-being lead. BME well-being lead. So I have a mixed view on this. I think it's really good to have someone who may have particular responsibility, but I worry a little bit about how that might be seen and where things have happened previously in other types of organisations where there's a person with a responsibility. What it can sometimes do, it means that people don't take responsibility for their own staff and their own staff well-being. So I worry a little bit about that, especially given what Terry said about culture change. So we all need to be able to work to develop culture, and I don't want this person, whoever they're going to be the person who, you know, anytime there's a conversation that needs to be had with a Black and Asian or minority ethnic staff, we kind of go to your wellbeing lead. You know, it's actually, how do we balance that out so that staff are encouraged to take responsibility and appropriately take responsibility for all staff that they manage and support, not just those that are white presenting. So I'm a bit worried about that. And the final point I had was I definitely agree that there needs to be some support for staff networks in terms of the day-to-day things that they're dealing with. I worry about the capacity and capability that we are that we need to promote, so that everybody has the opportunity to handle discriminatory issues and concerns. So we can't, I don't think we should be overburdening our networks with this issue as well. We should be making sure that everybody can respond to issues of grievances around issues around discrimination too. So sorry, Terry, it was a bit long-winded, but I hope you got the gist.
Yeah, I've got the gist.
Terry, let's pause that and give you a chance to respond to that, because I've got a little queue of Eileen and Jason afterwards, and we don't want to lose the things that you've had. So, all
right. So shall I kick off? So I'll start off with Claire's questions in relation to training. So what we have had is mandatory training in relation to equal opportunities. I don't think that's enough. And the proposal here is that we weave EDI training, EDI capability into all of the training, all of the leadership, all of the management training that we have. And so we're at the moment we're currently developing the CDs training. And one of the things that Bruno has said is really important is that we weave EDI into that CDs development program. So that's where we are, and that's where we're looking to head to. On the point about the whole reasonable adjustment, I agree that you know, just using the term reasonable adjustment is really vague. And it's not particularly helpful. I think setting up a cost center, I think that's fine, and that's something which you know, we haven't put in place yet, but we're looking to get that in place, and we've got a target and time frame for that, so it's not in place yet. But I think actually we've got a legal responsibility to actually make legal adjustments, and actually I think we'll need to take, you know, if somebody needs a reasonable adjustment, we need to do it. And actually I want that escalated if there's a feel, or if somebody feels that they're not getting the equipment they need to do their job. I want that escalated so that actually we align with legislation and the law. So I think that's the cost center is a process, and that will help. But actually, even before that process comes into place, I want it escalated, and I want the business partners throughout the divisions to make sure that that process is in place. I think, Katie, your point about freedom to speak up, I think is vitally important. We've seen that some people have gone down the freedom to speak up route when they haven't had confidence in our internal processes and systems. And what we are looking to do is build that confidence within the workforce team, so that actually, you know, people can get the right advice and also be signposted as well appropriately. In terms of the whole point about the BAME wellbeing lead, I agree with you, Joy, that actually that can't, can't have the responsibility on one person to be that conduit for everything, and that's not what this post is about. This post is funded by the charity, and what it is all about is about making sure that we've got the processes in place, so that actually everybody can get the health and well-being that they need. And you know, this was particularly at a time where we knew that BAME staff were disproportionately affected via COVID. So it's about the processes and the systems and setting those up. It's a fixed term post. We are actually going out to advert right now for a short seconded at senior level to make sure that actually we can embed some of those processes in place to make sure that actually it's not something which is dependent on the staff network or is dependent on any individual. Coming to the staff network point as well that you were making, I think we're quite clear that actually we can't overburden the staff networks, and one of the things that all of the execs have done, because we've got an exec lead for each network, and they're all putting forward a case for actually what do they need in order to do their job effectively. So for example, there's a proposal coming through around should we be utilising Stonewall and the cost for Stonewall? There's another proposal coming from another network about actually what time do they need back in order to do their job effectively. So that's all included, and that business case will be coming, and we'll go to the business planning group and to TME so that we can make sure that people have the support that they need in order to push forward. I've gone through that quite quickly. I don't know if anybody wants to come back.
I'm going to.
It's very helpful. Thanks, Shane.
I'm going to just encourage us to move on at this point. There's a sort of generic issue then, which is the difference between the special things we need to do to focus our attention and actually the fact that we just need to manage and lead and support each other well, irrespective of those things. And we need both of those things to happen. Okay, I now have a queue of Eileen, Jason, Sam, and Sarah Horden. So I'm going to go through those four and then hopefully go back to Terry after those. Eileen.
Thank you, Chair. Just a very quick reflection and a verbal reassurance on Katie's point about FTSE. Katie, thank you. It's a really important point, and the linkage between the things has actually been one of the core things we considered in the FTSE project. And Susan Paluca, who I know is on this call supporting the project, met with all of the different networks, BAME, disabled, gender, etc., to understand what might be some of the barriers to colleagues in those areas. And only yesterday, when we met as a project team, Matt Akid, our Director of Comms, reminded us of the opportunities to work closely during Freedom to Speak Up Month in October, in connecting up with Black History Month and also with other activities that are going on, such as staff surveys. So I think for me, having sat around the board for a long time, I think what we are really seeing now is much more emphasis on the joined up activity and on the collaborative focus right across all of these silos of work that have carried on as silos in the past and are now forming together much more into a tight network. Lots to do, but I think we're going in the right direction.
Thanks. Jason.
Thanks, Chair. It's a comment more than a question, really. It's something that didn't actually occur to me at TME. So sorry, Terry. Otherwise, you might have had a chance to reflect the comment in the paper. It was just to observe that one aspect of this paper is, of course, reporting to the board on the EDI issues where there is sort of some quite strict external reporting, which of course isn't 100% of the EDI issues that we're working on as a trust. And I just thought, and there may be a question actually in here, Terry, that one of the activities not reported on in the paper particularly is the work we're doing for LGBT staff. I think probably because there isn't currently, you won't thank me for asking this question, there isn't actually any national reporting requirement in that area to compare to, for example, RES or some of the salary work or such like. And I just wonder, since we're in NHS Pride Week, if you're aware of any even move to actually improve the national reporting actually of how the NHS is handling EDI issues for LGBT staff?
So not at the moment. There are proposals that are coming out of the futures work in terms of HR and OD, which will be looking at some of the protected characteristics, other parts of the protected characteristics. We are required to monitor, though, around where there are particular issues, and those issues which come up in relation to any protected characteristics. When we've looked at that data, there hasn't come out any startling issues in relation to the LGBT arena, but the ones that we've highlighted, like the medical, the res, and the gender pay gap, those are the ones which have highlighted that there's a particular issue.
Thanks, Terry. Sam.
Thank you, Chair. Just a couple of comments that I've been discussing with Terry and Joy actually in the background. I think in terms of timeliness, it's I'm the exec lead for the BAME group, who I think have lost their way a little bit. I've been seeking a bit of advice from Terry and Joy, and I know that as chair, you're considering sort of what the board level development is, particularly in this arena and following the staff story, and it might be timely for all of the exec sponsors to get together and consider where their networks are heading, because Terry and I are trying to veer particularly the BAME network away from where they believe they've kind of got a caseload and are almost positively circumnavigating away from what we're encouraging, good line management and freedom to speak up, and rather focus on, you know, 2 or 3 key areas of improvement. So one of the areas we're reviewing is what does training and awareness look like at every level, similar to safeguarding, you know, awareness, training and capability dependent on level of staff. So just wanted to make that comment, but it might be across all networks.
Yeah, I think that's helpful, Sam. I think one of the key points around the signposting piece is to make it really clear to each network, okay, this is your responsibility. You know, if you get in a bullying harassment claim, this is where you direct people. If there's an issue around training, this is how you direct people appropriately, and so that piece was put in specifically to address that issue. So the team is working on that, so that can be really clear, so that actually the networks can actually do what they're there for, rather than getting bogged down in just negativity. They can look at co-creating solutions rather than just focusing on the problem.
Thanks, Joe. Just laughing at Claire's dog removal service that's just gone behind her. Sarah, and then Megan, and then I want to try and move the agenda on because we have a couple of other items we need to spend some time discussing. Sarah.
Thanks, Jonathan. I just want to go back to the reasonable adjustment point. And absolutely, we should be making sure that people are given the support they needed, and there's a way to get that support centrally if we need to. But I would be really keen that long term, actually, we aim higher than that. So I think, you know, as someone who needs reasonable adjustment and who is quite proud and doesn't like to have to ask, I just put the context. I would like us to get to a point where people are not having to ask, where actually we're observing the people around us and observing what they find difficult or challenging and offering them support and offering them ways of giving of their best, so that it can feel really difficult to ask someone to do something which puts them out slightly in order to make your life doable or manageable. And so can I just encourage you to think about that as the kind of the golden success?
I can see thoughts from Terry, Sarah. I mean, I think the plus side of reasonable adjustments is it points out it's the organisation's job to change. It's not the fault of the persons and the requirement for them to change. The downside is it makes it sound like it's person specific, whereas actually what it needs to be is good organisation in which everybody can thrive. So I think absolutely, Sarah, that's well made. Terry, I could see you nodding, but you're welcome to add to that.
No, I think that's exactly where we need to be, and part of the action we're taking now is how do we work effectively with people who also become disabled in employment, and how do we get them to a place where actually they let us know, or when they work with occupational health, that actually those occupational health, actively ask the question and encourage people to share that information with their managers, or where occupational health can let us know directly, so that actually we can do something as soon as something happens. And what we're also seeing is that actually, just as you say, people don't even want to say they're disabled. So there's a disparity between people who record on ESR around when they start that they're disabled, but actually when they go to occupational health, it's quite clear that they've got a long-term condition. And when we look at the staff survey, more people say that they're disabled. So there's a lot of work to be done on that. So that's really helpful to highlight that we should be aiming for that as a goal.
I guess, Terry, I would say even needing to use that language is not quite getting to where Sarah's saying we should be, because actually if our managers are getting the best out of their staff, they're creating an environment which enables everybody to perform as well as they can. And whether or not they come into some category, and whether we describe them as, we all work differently, and good leadership will just spot the way to create an environment in which we all thrive without anyone needing to say anything. I think fundamentally, Sarah, that's what we aspire to. We may have to get to that by using these sorts of languages, but it's not where we intend to stop, I think.
Yeah.
Enough.
Thank you, Jonathan. Just a short comment. Terry, there's a reference in the paper to the medical res, which is the first ever national report, which was published in July this year. And it is quite stark. And I think, I know we are going to work on this together, but I think when we consider the paper on AAC further today, I think the findings of the MRES should be incorporated in the guidance there for all of us.
Yeah, definitely.
Thank you. I think then that's probably what we need to discuss in terms of the quality standards report. I think, Terry, there's plenty of stuff to be going on and feeding into things there, but there's nothing that actually is really fundamentally different from the direction of travel that you set out. I guess it would be lovely to say we could make a big step change, but we need to recognise this is probably a lot of small things that add up to a major cultural transformation, and we need to keep plugging away. Can I move us on then to item 11, which is the CQC's maternity report? People will have seen this report already. It's not in itself in the pack because it's on the website and there's a link to it, but everyone would have seen it circulated. I guess I'd just make two observations before I hand over. I mean, one is that I take some assurance from the fact that the CQC visit being triggered by issues being raised on whistleblowing, the same issues have come up through our freedom to speak up process, and which I know Terry is suing them is in hand and getting to the bottom of what was there. And actually, it's reassuring that we would have picked this up without the CQC, and it's always better to have two ways of picking up those sorts of concerns. Once they came, though, my overwhelming impression of the report, despite the grading that CQC did, was actually I saw lots of things that were moving in the right direction that we've heard previously were challenges in the maternity service. So there's lots in this report that shows us that the work we've been doing has been improving the quality of care that those services give. It, of course, leaves us with a number of things that we still need to work on, some of which I'm sure will be quite frustrating from colleagues who feel that we've made progress and that we haven't quite got it as uniformly as we need to. So the purpose today is to focus not on the content of the report so much as what we're going to do as a result of that report, because we've already had a chance to digest the content. Eileen.
Thank you, Chair. Given the fact that we have all seen it and it is also available to our public via the CQC website, I think it is right that we emphasise where we go next. I know that the teams, and I'm sure Sam will, as the executive lead, will wish to come in and talk about the work she's been doing with the teams following, both leading up to the report and following the receipt of the report. as to how we can change that rating and how we can look to start reversing the change that we received as a consequence of the inspection. These inspections have quite an impact on teams because they pride themselves on trying to deliver the very best care. We saw examples of that right at the beginning in another area of maternal services. So these reports they receive probably sometimes focusing more on the things that they need to improve on, which is quite right from our learning perspective. But also I think as a board, we should encourage the teams quite heavily. And I know Sam and the whole executive have been encouraging the teams to also reflect on the very many good and positive things that were found by CQC in this review report. The next steps now involve us. We have already commenced working on an action plan to address the 2 sets of actions that we've been required to comply with. One are called the must-dos, and those are the ones where it's classified as a legal breach in relation to the regulation. And then there are some should-dos, which are either advisory actions or actions that they would encourage us to take to avoid any potential breach in the future. Overall, I think it's a balanced report. As somebody who has participated in CQC inspections many times before, there is always room for opportunity, and there's always room for improvement and an opportunity to learn. I think this report points us in the direction of those, some of which we knew about, as you've referenced, and some which were disappointing because they were almost balls dropped at a specific point in time, which we will and the team are already focusing on or have taken immediate action. At that point, I pause and hope that the report has been fairly clear to people, and invite Sam if she wishes to add anything about the support to staff.
She does, Sam.
I'll be really brief in the interest of time. I think, as to echo, as the chair said, the report wasn't a surprise to us. So I think that we were able to discuss with CQC a number of areas that they raised with us as part of our engagement with them. We were already aware of and were progressing actions against. As Eileen says, the staff are deeply disappointed, particularly in some of the sort of business as usual actions that we have been able to rectify since, but that is learning for the team. The national team have put out a new document, a self-assessment document, which is specifically aimed at increasing overall CQC rating from requires improvement. And whilst there is a sort of significant amount of national requirements for us to report on maternity, this tool does look very useful. So the team are currently populating that. I'll probably leave it at that, otherwise we could talk all morning probably, but I can give assurance that the team are very engaged in the improvements and very driven to change that rating back.
Thanks very much, Sam. Are there any other? I know a number of people had a chance to discuss this separately, including Tony, who I would have gone to next as the maternity champion amongst the non-execs had he not been on leave, but he's been involved in discussions as the report came in. Meghana.
Thanks, Jonathan. I just wanted to recognise the hard work of this group of staff who, as you know, throughout COVID, the numbers of care patients that they looked after has not decreased, and in fact the complexity has increased, especially with the need for level 2 PPE, etc. And there is a lot of good practice highlighted in this report. So I think that is good news, and as Sam and Eileen have said, the learning is there. So we are on our way, well on our way to make sure that we get this rating changed at the quickest possibility.
Thanks, Meghana. And I mean, I know the culture stuff we need to understand more, and there's working on to do that. But all the other areas for improvement are really about consistency. So they're about the fact that this didn't always happen, and we know that we sometimes deliver exactly what we hope to do, and sometimes we don't. And that suggests that we just need to keep plugging away at the things that are already identified as appropriate. I hope that if we do that, the rating will follow. But of course, the reason we do it is not the rating. The reason we do it is it delivers the quality of care that our staff want to deliver, and to deliver that consistently. Okay, I think then that's probably what the board needs to do today. We will pick up the monitoring of the action plan in due course, but the key thing today is to recognise the CQC report, to note that we have already an action plan underway and implementation, which will come back through our normal assurance processes. We stick with maternity, but we need to pick up the maternity incentive scheme paper. So we're with you now, Sam, I think.
Thank you, Chair. So for Public Board, there are 3 papers to consider today, all of which have been discussed at the Maternity Governance Committee, the divisional appropriate forums. A number of areas have been discussed at the Trust Clinical Governance Committee, which is co-chaired by Megan and I, and Tony Shapiro and I have reviewed all of this information as board safety champions. So I guess the overall aim is that we moving forward, as with all other trusts, are aiming for an integrated report that's much more along the lines of a board executive summary, and we've been feeding into the national team as they continue to increase the amount of detail which is required to be presented at board level. So apologies that due to some of the operational pressures that we're suffering at the moment, we haven't been able to bring that into a more integrated board fit paper, but we are in progress of doing that. So in terms of the Year 4 Maternity Incentive Scheme, the paper is aimed to give a brief update on the 10 maternity safety actions, which are included as part of the NHS Resolution MIS Year 4, which was launched in August 2021. We talked, the aim is really to demonstrate that we've achieved full compliance with the 10 safety actions for patients, and we'll recover our contribution around the CNST as incentive fund. And the board need to be satisfied that the evidence provided is to demonstrate the achievement of the 10 safety actions. The content of the declaration form needs to be signed with the Commissioner and the Chief Executive, and there are a range of issues which pertain. I talked to the board last year that Year 4 of the MIS was going to get more difficult, so this is really to share with the board that whilst we've achieved Year 3, Year 4 shows significant changes to the requirements. I can assure the board that we're working as an executive with the teams, particularly around neonatal staffing, and David's team are leading around the IT elements where we need to bring in a maternity information system. The other element that I need to bring to the board's attention is to note the overall compliance in relation to maternity staffing. So things have changed fairly dramatically over the last couple of weeks in relation to our maternity staffing. We're fairly constrained by unavailability, particularly around sickness. We have circa 35% of our workforce absent at the moment, which is due to maternity leave, and there's a requirement for maternity leave to start earlier at 28 weeks due to COVID restrictions and sickness management of both COVID and non-COVID, predominantly non-COVID sickness management. When we add the annual leave and the study leave onto that, that gives us a total absence rate of circa 35%. This is not unique to us, and we participate in 3 times a week regional sit rep, and we're seeing across the whole of the South East and indeed nationally consolidation of staffing, which requires us intermittently to take down a number of services. So as we stand today, both the Chipping Norton and Wantage midwifery-led units are currently not available for women to birth in. We've been working alongside Maternity Voices Partnership and our regional teams who are monitoring the situation, and there's some comms which are going out today and further sort of wider sharing on the radio station. I think that our Director of Midwifery is going to be on the radio tomorrow. So whilst I can give assurance around our planned staffing, in fact our current establishment, we are over-established with midwives, and there was, again, if we triangulate good assurance in the CQC report, due to unplanned absence, as Jason was not challenging me, but just checking in with me yesterday, that Birth Rate Plus does recommend planned staffing to cover our services. It's this level of unplanned absence which exceeds the planned headroom, which is really making difficulties operationally. And then the third area that we've covered as part of Public Board, which I think provides really interesting benchmarking. Just in the interest of time, I won't go through the benchmarking and the conclusions of that, but it's there for information. It's something that I've shared with the Chairman and Tony previously, and I think provides, as the Chairman said, some of the gap around where we sit nationally as a service in Oxfordshire.
Thanks, Sam. So just remind us what we need to do as a board. This is we need to note the contents of this. Are there any particular decisions you need us to take?
No, not at the moment. It's to inform the board around the challenges for Year 4 MIS. It was to give assurance around the staffing, but I really need to flag the current operational pressures, and the Dr. Foster is for noting. I don't think there's anything particular in there to highlight.
Can I encourage the board then to note those things in view of the time at 11:45. I find the Dr. Foster stuff fascinating, but I'll resist the temptation to discuss it now. I can pick it up at another time. We then move to a series of things that probably, I hope, won't take us quite as long to focus on. The first of which is the Declaration of Interest, Gifts, Hospitality and Sponsorship policy, which is recommended to us by TME for approval. Eileen, is there anything you want to draw our attention to before I put that question to the...
No, thank you, Chair. I think it's been well circulated. Susan has done an extensive amount of work looking at others as well to ensure where we can learn further lessons. And she may wish to comment, but in particular, one of the challenges is ensuring compliance with the policy, not just the fact that the policy is compliant with the law. And I think we're very cognizant as an executive collectively that this remains an area where we will need to consider the processes that we use to underpin that. And I think Susan has made reference clearly in the paper to the need to consider a digital solution to align with our values of digital by default.
Broadly, I suspect it's quite easy to comply with the Declaration of Interests, and it's a bit more complex complying with the other questions. So I think perhaps I'll just commend it to the board, pointing out that the thing we're formally doing is approving the policy, but we're also reminding ourselves that we also need to comply with this, and that gives us just a chance to check that we have done, and if we're not sure how to, we can ask. Are we content on that basis then to approve the policy? Thank you very much. I see nods. The next paper is the handling of concerns related to conduct capability of health, medical and dental practitioners. We have had drawn to our attention in relation to some tricky places that our policies are not necessarily identical to national guidance. I think we now have had a chance to review whether or not that implies that they should change, and that fundamentally is what lies behind this paper, as I understand it. Terry, is that right?
Yeah, and basically updating some outmoded language, and also just changing some musts to should haves in areas where it's unlikely for us to meet the procedure. So essentially, we're just asking the board to approve this amendment, which has also been through our local negotiation committee and through TME as well.
Thank you.
Wants to come in?
Sounds like you made that point.
I think you just made the point I was going to say, so that's fine.
So on that basis, can I invite the board to agree that that policy? I can. Okay, we need to take slightly longer on the next paper. Colleagues will remember that as part of our COVID governance, we had identified that we were, as a board, prepared to depart from national guidance where it was the right thing to do in the interests of our patients and staff, but that the board needed to accept responsibility for doing that. It wasn't fair for the executive team to do that without cover. And that, as I understand it, Meghna, is what lies behind this. Are you taking this as CMO, you giving it to Elaine, or drawing Katie's paper?
If I could take it as CEO and then invite Katie, is that okay, Jonathan? So essentially, as many of you know, that we need pre-procedure 72 hours pre-procedure PCR for all elective treatment and procedures. So the particular impact of this, as we've noticed, is on procedures that are day case, like endoscopies, and that's not upper GI tract, but lower GI tract, so colonoscopies, and procedures or operations that are day case under local anesthetics, such as cataract or glaucoma. We've seen that patients are reluctant to have these pre-72-hour PCRs, and therefore the attendance is reduced, which then has an impact on our endoscopy, waiting lists, etc. And this paper is here as a derogation to national policy, and it provides and supports evidence, which Katie will further highlight, to the use of lateral flow devices, either on the day or just before arriving, or if patients are not able to undertake those lateral flow tests before they arrive, then on arrival at the unit, and to make sure that those lateral flow tests are negative, but also that all other precautions are taken in terms of assessment of that patient on the day before we proceed to that endoscopy or that procedure under local anesthetic, as this will promote productivity and will also enhance patient experience for those undergoing those particular procedures. This has been approved by TME, subject to scientific evidence, which is provided in section 4, which Katie will, I'm sure, be happy to answer and detail further. So I would really like to seek board approval for this derogation from national policy, but also would like to say at the same time that if anything changes, such as the rates of infection in the community, etc., we will of course then go back to the original.
Thanks so much, Megan. We couldn't be luckier than having Katie as part of this process in terms of advising us. But as I understand it, fundamentally you're saying we believe this is in the interests of patients and it's scientifically sound to take that step.
Yeah.
Katie, is there anything you want to add?
Thank you, Chair. I would just like to add, to put this into context, remember that the NICE guidance, which we're asking for permission to derogate from, was written in July of last year. So this was before vaccination was available, and it was before the widespread availability and scientific understanding of the role of lateral flow testing. So I believe this is a very safe thing to do and will promote patient safety by bringing them forwards for their cancer screening procedures, for their cataract procedures, etc.
Thank you very much. That's a strong recommendation, which I think the paper supports. Is the board content to accept it? It is. Thank you. That's a brief acceptance, but that's because of the background preparation that's gone in, and we're very reassured by that. Thank you. We now have a number of items which are mostly receive and notes, although if I forget that there's an approval required in the IAC, someone will stop me and pick up that. The first of those is the flu vaccination self-assessment, which I said sits with you, Sam. We're asked to receive that paper, which sets out where we think we are, but perhaps you should just remind us as whether you think we're in a good place as well as just where we are.
So this is a joint paper from Megan and myself. Megan is the executive lead. I'm running the operational task force, the sort of clinical operational element. So I guess the only thing to add, and it changes most days and all execs have got a role, whether it's data or denominator, we're all very involved in this. The update we had this morning is that there's not likely to be a delay. People will have seen on the news the potential lorry driver delay. So we've had information that there's not likely to be a delay, and we'll continue to meet weekly. There's a requirement for the board to receive the checklist and be assured that we have a plan. But what we have is a winter vaccine plan, and we're incorporating any elements of the COVID booster as things emerge. So we're just very lucky. We have a great bunch of people working with us, and we're confident that we'll be able to deliver the programme, however that looks.
Thanks, Sam. Ordinarily, we would all be in the same place and you would have the pleasure of stabbing us to get your own back on us for awkward things that we've said during the year. So perhaps in due course, we'll need to work out how board colleagues, get their vaccinations and lead by example. If we do find ourselves with a shortage, I would not be keen on the board being seen to get jabs before staff who are more exposed to risk in the front line. So I don't think we should take any position on how we do that, but I'm sure you'll update us in due course about what the plans are for those of us who are not necessarily in the trust or not in every day. With that, can I confirm then the board receives that paper? Thank you. We then have a number of annual reports, the first of which is adult and children's safeguarding. And Sam, I should give you a chance to say anything because I know you were having a conversation with Anita in the coffee break, and I think I heard you say there was something you might just put on the record in this point.
Thank you, Chair. Just a couple of brief notes. The purpose of the paper is really to give assurance to the Trust Board of the organisation's participation in effective multi-agency working to safeguard adults and children and staff, actually. Anita raised an important point with me, just requesting an update as to how we operate now, particularly with education. And I was able to share with her that now, probably for a number of years, actually nationally, there's a requirement for us to operate in something called the MASH, the Multi-Agency Safeguarding Hub, where a team is co-located from education, police and health and social care, and they work collectively to review and triage referrals and progress actions in relation to any protection plans. So I can give assurance around our really effective multi-agency working with our colleagues. And this is in relation to both adults, children, and you'll see some annotation in there around the designated safeguarding officer, because Megan and I have to frequently consider safeguarding issues in relation to our staff. I think it's important for the board to note the increase in referrals, and just going back to the previous conversation, there's some reference in there around patterns of referrals, particularly to Oxford during the COVID period. And give the board assurance that we have got the requirement for us to implement the new liberty protection standards. That's on our radar, slightly nationally delayed, but certainly on our radar to review collectively, and also to note the challenges to the service, as previously noted, particularly in relation to adolescent care.
Thanks so much, Sam. Given that we discussed safeguarding a bit earlier, I'd like to just invite the board just to receive that report with that additional information that Sam's just offered us. Is there anything people particularly want to raise? That's great. We do regularly ask questions about that, and we have the IPR helping us on that. And that's also true of the next item on prevention and control. This is the annual report, but of course, because we receive information each time we meet with the IPR, Meghna, you often have to field questions in your CMO role. You can divert those to Elaine, but she'll probably want also to pull in Katie. I wonder whether I could invite, and I don't know who you think is best placed to answer it. I think it would be great just to hear specifically a little bit about nosocomial infections and COVID, because we have been very anxious about both our staff and also patients coming in. And I think the position is that colleagues have done a good job on that through COVID, and we have a bit of a picture. You know, there are trusts where a quarter of the patients caught the caught the disease when they're in hospital, and our picture, I think, is very encouraging in terms of the care that staff took. So, Meghna, who would you like to answer that question?
Chair, Katie will answer that, but could I just say a couple of words first? So so obviously IPC has been at the forefront of everything that we've done in the last 2 years. And I would like to just note a formal thanks to Katie and also to Lisa Butcher for their leadership of taking us through this time, for making sure that everybody was fully aware and at the top of their performance where IPC was concerned, and always being a step ahead of national guidance. And from me as the chair of the steering group, and for everybody else in the COVID silver and gold group, I think Katie's advice was always there and always perfect, which allowed us to make those decisions that we did to steer ourselves out of this pandemic. And again, you know, I know for a fact that we are one of the lowest nosocomial rates in the country, and that there's a significant amount of learning between the first and the second waves, which enabled us to lower nosocomial rates even further. So Katie, over to you to discuss this particular answer and any other aspects of the report that the chair or the board members would ask.
Thank you, Meghna. That's very much appreciated, and thank you, Chair, for this opportunity. This has indeed been an incredibly challenging year. I'd like to thank Meghna and the Trust Exec team for support, but in particular, I'd just like to thank 3 teams for their extraordinary work rate, teamwork and resilience. The infection control nurse team led by Lisa, the laboratory team who performed miracles in terms of COVID testing, and the staff testing team. So those 3 teams combined really have kept our patients and staff safe. And I'd also like to acknowledge the very significant contribution of the university, who've provided additional space for us to set up a dedicated COVID testing laboratory, and also, of course, medical students who helped out a lot with testing. So a very challenging year indeed. In terms of nosocomial COVID, we have looked very carefully at the cases that occurred in the first wave and in the second wave. And I'd just like you to consider that in the first wave, the number of cases is very much under ascertained because we did not have diagnostics in that first wave, and you could not get a test for anybody who presented without fever, cough, and travel from Italy. So it was a very difficult time for the Trust, and we had a very significant amount of COVID upon level 7 on our medical wards, as was reported to you in last year's annual report. But I'm very pleased to say that of those cases we have ascertained between the first and second wave, we've got a statistically significant reduction in the number of cases in the second wave. And I believe that is because of our learning from the first wave and our application of that learning. And in particular, I think this is very much about being able to move away from embedding PPE and all those infection control practices, hierarchy of controls, to actually having infection control nurses on the ground 7 days a week, looking at every case, making sure that every patient was in a place of safety, and similarly with the staff team who were following up every single contact and making sure that every member of staff was also safe and safely looked after. So I think we can clearly demonstrate here learning from the first wave into the second wave, and that we've done our very best to keep our patients and our staff safe, and that's been a huge team effort.
Thanks very much, Katie. I know that will be echoed by people because they've picked that up as we've gone through and queries on the stats that have come through. Meghana.
Thank you, Chair. I just also wanted to acknowledge that whilst we've managed COVID pandemic extremely well, we have seen in board reports that our numbers of cases for C. diff particularly have for various reasons, multifactorial reasons, have been over the trajectory that we had for the previous year, not last year, because one wasn't set for last year. And we do have an action plan which is being followed, and all the divisional teams are aware, and we seek assurance through our governance routes that these actions are being followed, the 7-point IPC plan and the antimicrobial prescribing, as it were, to make sure that we do control and reduce the rates of C. diff and MRSA and MSSA.
Thank you. In view of the time, I'm going to encourage us to move on. Katie, we always ask about some of the infection issues because they always pop up on the IPR, and Meghana usually has to bear the brunt of the answers, but we know that she's heavily reliant on you and your colleagues for making sure she has the information, and it's great to have the opportunity to just take stock as we do annually. And I think the board is acutely aware how tricky this has been and how well you and colleagues have supported each other, our patients and our staff, during the pandemic. I wish I could say I think it's gone, but we can't, can we? If we can't take our eye off this ball at all, and we were discussing earlier how important it is to keep our visiting restrictions and our masks and social distancing, because it's we're looking after vulnerable people and our staff are exposed, and if we don't get that right, then we won't do as well next year as we've done this year. So thank you very much for that, and I hope you will pass back the thanks of the board to those people you singled out for mention, but also pat yourself on the back as well, because as Meghana said, we absolutely appreciate the work that you and colleagues have done on this. Thank you.
Thank you.
We now have Learning from Death's annual report. We're at 12:03, so I don't want to prolong unless we need to. Meghana or Elaine, is there anything you particularly want to draw our attention to on the Learning from Death's report?
Yeah, thanks, Meghana. Thanks, Chair. Just a short summary, really. This paper for information to provide assurance to the board in terms of evidence of learning from deaths as a result of our mortality review process. So can report that 95.4% of deaths were reviewed within 8 weeks. And then just to draw attention really to the breadth and across the trust and the different types of learning opportunities, and really across a number of headings: communication pathways, procedural changes, educational opportunities. So just to pick out a couple, a move in neurosurgery to mini open craniotomy biopsy away from closed biopsy, communication between ED and general practice in terms of management of blunt chest trauma. Very good work in paediatric intensive care, looking at compassionate extubation in the hospice setting, and work around tracheostomy, both in AICU and for stroke patients. So I would ask the board to note and receive this report. Thank you.
Thank you very much, Elaine. Are there any particular things that people would wish to pick up? We now have a much more systematic review of deaths, than we have in years gone by, and I'm very relieved to see that we're using that systematic to close the loop. So I think the board needs to take assurance, mainly from the fact that things happen as a result of these reviews, rather than the fact that they're just happening, because otherwise it's just effort that doesn't deliver improvements. But there's very clear evidence that this is not a trust that does that. This is a trust that seeks to learn. Okay, thank you very much then. So that takes us on to the Responsible Officer's Annual Medical Appraisal Revalidation Report. Are you delegating that to Megan, or as this sits with you? So Elaine, are you taking this one too?
I am. No, this is definitely mine. Thank you, Chair. So obviously an extraordinary year for revalidation, entirely remote for the team working and obviously for the appraisals themselves being conducted. I'm delighted to report that compliance for appraisal sits at 96.87%. And in fact, if we correct for the impact of COVID, that rises to 99.14%. And I really would like to pass on my thanks to the revalidation team for their extraordinary efforts in delivering that outcome. Just to contextualise that, the actual appraisal process was suspended by the GMC and NHS England from March to July 20 and from January to April 21. And that has created a huge disruption in terms of the demand, in terms of big peaks of work as people return to the process, which the team have managed very well. And we are actively now managing the challenge of maintaining both engagement and respect for the process with success in our metrics, I believe. Thank you.
Thanks very much, Elaine. And I know when we look at the review of the action plan, COVID has stopped most of those things happening. So to have got us back to that despite COVID, I think is very impressive. Megan.
Thank you, Chair. Just one thing to follow up on, Neil, that this report has to be submitted to NHS England with the Chief Executive and Chair signatures, as we do every year. So your help with that would be most appreciated.
Thank you. And I'm sure everyone will have noticed, but we're in the transition for Helen Douglas House and Catherine House. So we need to note the statements of compliance there as well as our own. Okay, thank you very much. That takes us on to the TME report. We don't usually need to discuss things on that. Megan, is there anything we need to discuss on that now?
Nothing from me, Chair. Nothing from me to raise. Happy to answer questions.
Thank you. No one else is jumping in. On the integrated assurance report, we do need to note that there's a recommendation that to approve the April to September 2021 budget. You'll remember that things got out of cycle. The IAC, which includes all board members plus TME, recommends that. I sort of assume, Jason, that's it's already working its way through the system, so we do need to formally approve it, but you're working on the basis.
That's great, Jonathan. This is sort of product of a conversation I had with Anne in your absence about, given where we were in the IAC conversation, the efficient conduct of today's business and not creating a large extra item, but you'll see the IAC content is appended in summary.
So I'm going to take it, unless anybody objects, that the record can show that we accept the recommendation from IAC to approve that. And then we have the consultant appointment signing document, which is for information. I'm not aware of any other business, so although we're a little late, I hope we can stop at that point. Excellent. So we meet again in public on the 10th of November, but if we were in public, I would be reading out the words about adjourning to deal with business as a confidential matter. So we will, other than our visitors, be reconvening at 1 o'clock for those elements of confidential business that need to be dealt with by the board today. Thank you very much, everybody, for bearing with us. I know it's a little longer than expected, but we had some meaty items today, and I'm very grateful for everybody working their way through. So thank you very much. And that's the end of the meeting.